Hi, today's topic is Bartholin cyst management. Bartholin cyst is basically a swelling over with and without inflammation at 4 o'clock or 8 o'clock position on the vulvar vestibule, and it is responsible for the 2% of the gynecological visit. I'm sure many patient comes, they are young, just married or sometimes unmarried, and they come with a vulval swelling, and that there can be a Bartholin cyst. It can be abscess also. So Bartholin cyst is basically a disease of reproductive age, and this type of swelling you can see on the vulval side, which is extending inside also, and it's not that uncommon. Bartholin gland is located just beneath the fascia and drain into the vestibule. It is 0.5 centimeter size. It's a very small gland which is very close to the vestibule, and it is a mucus secreting gland, and its role is a lubrication during sex or anything. The role of lubrication is there, and this is the basically you can see this is these two Bartholin cysts are there. They are almost a size of 0.5 centimeter, and there is a duct which opens into the inside the vagina, and this is a Bartholin gland. So etiology and symptoms, when we see the patients of Bartholin cyst, it's basically the Bartholin duct blocks because of it can be caused by trauma. It's a sexual activity. Sometimes it's due to childbirth or a big episiotomy, and it stitched the Bartholin. Then inflammation is there, and patient comes with cysts are sometimes painless and vary from 1 to 5 centimeter in size. Though we know the Bartholin gland is only 0.5 centimeter, but we can see the cyst up to the 5 centimeter of size, and larger cyst can cause discomfort, dyspareunia, and sometimes these cysts end up into the abscesses, which are painful, and this is with and without the fever or the pus discharge. Now, what are the common pathogens which can cause, and what antibiotics are good for this? The most common pathogen is E. coli, and other are gram-negative aerobes. Staphylococcus aureus is also very important because we see in the vagina there is many times Staphylococcus aureus is responsible for other infections also. Then MRSA is also very, very important. Then the standard vaginal floral organisms, which are important. And in adolescents, chlamydia and gonorrhea are frequent ones. So when we see the patients of Bartholin cyst, we are supposed to find it out what is the basic pathogen should be, and the right antibiotic should be given. So for E. coli, we give amoxicillin and a clavulanic acid. Then for other gram-negative, clindamycin. For Staphylococcus, cefoxitin and clindamycin. And MRSA, we give ceftriaxone. And then for standard vaginal floral organism, though it's an old standard treatment, still the trimethoprim and sulfamethoxazole are important. And ciprofloxacin has got the role. And doxycycline has got the role. It should be given properly. Then adolescent chlamydia and gonorrhea, azithromycin should be given. So how to differentiate diagnosis with other cyst inclusion cyst? We are supposed to differentiate with sebaceous cyst. Sometimes there is a sebaceous cyst also. Then very rarely, but we should keep into the mind that the vulvar angiomyofibroblastoma should be there. So we should be careful while giving the treatment. Then the episiotomy scar and endometriosis is another important point. We should think about it. Then there is a perineal leiomyoma, means a small fibroid or the tumor which is on the perineal region, which we have to differentiate between the Bartholin cyst and all other conditions. Sometimes there is a ischiorectal abscess which is draining outside, and there is a big abscess we can see. Then folliculitis, sometimes a hair follicle or something, and folliculitis can happen at that location. And rarely the adenocarcinoma of the Bartholin cyst we should be considered about. Now, Bartholin gland carcinoma, just putting few words about it. That's a carcinoma of Bartholin gland is 5% of all vulval cancers. So we should be worried about any postmenopausal women coming with a Bartholin cyst. Think about the carcinoma of the Bartholin gland, and that's important. And average age is 57 years. That's a solid non-tender lump, and these are the problems. Now, what is the treatment and what are the indications for the biopsy? When the diagnosis is uncertain, there is unusual pigmentation, and there is an induration, ulceration, and bleeding, and there is a rapid growth, and especially in the postmenopausal women at the post of Bartholin cyst, we should be worried, and we should take the pre-treatment biopsy, and there is a refractory vault over the vulva. Now, surgery or the Bartholin gland and abscess and cyst, what to be done and how it has to be done. Number one, the simplest one, incision and drainage. Then number two is incision and drainage with cavity closure. Number third is incision, drainage and insertion of a word catheter. Fourth is the incision and drainage with the insertion of Jacobi ring. It's basically the marsupialization with the interrupted and a continuous sutures, aspiration and alcohol sclerotherapy, incision, drainage and silver nitrate incision, sometimes the carbon dioxide laser therapy, cryotherapy, and total cyst excision is the last and most important. Now, what should be the ideal treatment for the Bartholin cyst and abscess? The fast and safe, performed in the outpatient under local anesthetic, no or uncommon recurrence, and rapid healing. Now, incision and drainage, incision with or without closure, incision and drainage with stent to epithelialize the tract. So we can have the word catheter which we can put and we can keep it not to be stitched. Number two, Jacobi ring is a small ring which can be inserted over there and it is used. And then this is the IND word catheter. Is a simple hole is like a catheter, but it's a very small. A balloon should be filled and should be kept there. It's OPD procedure. Word catheter made of latex. After incision of 3 mm, complete drainage, tip of the catheter is placed on the cavity, inflated 3 to 5 cc, normal saline and put inside and keep it for the Cyst bath after 24 hours, catheter to be removed after 4 to 6 weeks. And done under local anesthesia, very little analgesia is required. And catheter may lead to discomfort, chances of recurrence are common. Now, this is the Jacobi's ring. In place of the word catheter, Jacobi's ring is used. It's just like a small thread like a thing, and there is a covering or insulation over here. It can be simply made by the rubber catheter. It's less cumbersome. Advantage and disadvantage same as the word catheter, and that can be just give the incision, put this ring through it and stop it. First drain it, put the Jacobi's ring and tie it here. This can be done. Now, the marsupialization is the best for the treatment and incision of the vaginal entrance beyond the hymenal ring. Incision is extended upon 1.5 to 3 cm. Interrupted sutures are placed circumferentially, attaching the cyst wall and the fascia and the skin. Review in 1 week to assess the healing. Cyst baths after 24 hours. Post-operative antibiotics, analgesics are required as per requirement. So just simply give the incision, drain it out, and marsupialization is just open it, keep the sutures allowed and open it like that. Now there is an ablative procedures also with a silver nitrate insertion, carbon dioxide laser therapy. We sometimes do the cryotherapy, and active infection is contraindication for the ablation therapy. It's a chronic one, long standing this thing, and the pus is there and we can do it. So aspiration and silver nitrate application or the alcohol sclerotherapy are good and novel method for the management of Bartholin cyst or abscess. But the concluding way is alcohol sclerotherapy of Bartholin cyst or abscess are effective as silver nitrate application, and it is associated with less complication. It may be ideal, safe, and attractive treatment modality in these gynecological diseases. This is a treatment being talked about these Hasan-Kafai and EJ-OJO issues. Now, carbon dioxide laser therapy, it's another important. There is a lot more surgical data and a short and long-term results and a journal of minimal invasive gynecology. And this treatment of the virus can carried out safely, outpatient setting, minimum patient discovered, and high long-term cure rates. So another important. Bartholin cyst excision, indication recurrence, persistent deep infection, GA or local anesthesia, incision size of the size of the cyst, careful dissection around the cyst, and completely enucleated without rupture. Meticulous hemostasis, deep space to be obliterated with the absorbable sutures, and skin is closed with 40 absorbable subcuticular sutures. And placement of drain is optional. So simply just give the full incision around it, drain the everything and try to remove the whole cyst by just putting in it and just do the good hemostasis and just do the closure. Or sometimes the drain is there. Now, sometimes there are a lot many risks of doing the gland excision. Number one, that there is sudden hemorrhage is there. We can see the hematoma may form. Loss of vaginal lubrication. Sometimes it's removed everything and the vaginal lubrication lost. Scarring is there, which is painful for the long time, and dyspareunia can occur. Chronic pain and dyspareunia, and incomplete removal of the gland. As usual, there are so many recurrences. That's the most important point. Now, how to manage post-operatively? Antibiotics, analgesics, set baths after 24 hours, follow-up after 1 week. Now, evaluation of the treatment of Bartholin cyst abscess as systematic review. Current randomized trial evidence does not support the use of any single surgical intervention for the treatment of a symptomatic cyst and abscess of the Bartholin cyst. So we can use the mixed things this. And it does not indicate the difference rate of the recurrence and of the symptomatic cyst or abscess of the Bartholin cyst gland when compared with the marsupialization. Then another important point, insertion of the word catheters offer advantage on others, including the ability to undertake the procedure within the office and a setting. Avoidance of general anesthesia, reduction of the resources utilization, such as hospital beds and usage of operating theater time. That's more important. In my experience, 78 is cases we have done, and we have removed the 30 abscesses, 48. And so primary procedure, we did the marsupialization, excision in 8. Recurrence in my series is almost worst visit after 1 and 3 previous surgery, failure 5, complications, sometimes secondary hemorrhage, and that's not important. Thank you so much for the patient listening, and please like and subscribe my channel and forward it. Thank you so much.